gonna get started. So I'm Boduch. Thank you all for coming. Bear with me. I'm working on. There are two different screens and changing the slides, so if it looks like I'm going really slow, I apologize. But like I said, I'm Boduch. I am a dual fellowship-trained orthopedic surgeon. I specialize in sports medicine as well as trauma, and I work at Atlantic Orthopedics. And today I'm going to present on caring for the female athlete. So here is an overview of my presentation. To start, I'm going to tell you a little bit about myself and why this topic is particularly interesting to me. I plan to go over the risk factors that are very specific for female athletes in the population and why those are relative to the injuries that are more common and they relate to the risk factors that females have. I also am going to talk about some injury prevention strategies and ways to kind of stay in the game, stay in the pool, on the court, on the ice, whatever your sport or activity is that you like to do. And keeping female athletes, in the game is really important. And I think for both their mental and physical health, we know that female athletes have been shown to have higher self-esteem, better grades in high school. They have higher rates of high school graduation if they're on an athletics team, and they also have lower rates of depression and anxiety. And from the physical standpoint, they have as much as 30% increased bone mineral density as compared to non-athlete counterparts that are also females. And then I'm going to conclude my presentation with my perspective and sort of my treatment approach. Feel free to interrupt me with questions. I feel like when I'm at a talk, I think of a question and I forget it by the end of the talk. So if it's something relevant to the slide or you have a question, I don't mind at all if you raise your hand or just speak up. I'll try not to get too distracted. So just about me. Why is this so important to me? Well, I was a high school and college athlete. I was a 3-sport athlete at Winnicott High School in Hampton. I grew up in Northampton. I spent my whole life on the seacoast aside from my schooling. And I was on the cross country team, the basketball team, and the lacrosse team. The picture on the upper right, that's of me in high school. My senior year, we won the girls' state basketball championship for New Hampshire, which was very exciting for us. And then after graduating from Winnicott, I went on to the University of New Hampshire where I studied biochemistry and got my undergraduate degree at UNH in biochemistry. I was also on the rowing team when I was there. And so the bottom photo is, in college when I was rowing. This is the head of the Charles Regatta. I am sitting in the very middle of the boat. I was 4th seat for this race, so I'm like, let me see if this works. I am here. So this is a very long time ago, and I don't think any rowing photos are very flattering, but for me, it was really important to be a college athlete as well as a high school athlete. It taught me a lot. It kept me really motivated, and it kept me very regimented in my schedule, helped me stay studying and all the different things. So I really understand how important it is for people, men and women, but especially women, to be involved in athletics. After college, I went to Penn State. Well, I worked for 2 years actually after college. I worked in a research lab for 2 years before deciding to go back to school. And then when I decided to go back to school, I decided on medical school. I went to Penn State College of Medicine in Hershey, Pennsylvania for my medical degree. And then I went on to complete my orthopedic surgery training at Brown University in Rhode Island. After my orthopedic training, I completed two separate 1-year fellowships. One was in orthopedic trauma, and that was at Brown, and then a second fellowship that I completed was in sports medicine, and that was at the University of Pittsburgh. So I was one of 2 females in my residency program of 36 residents. As of 2019, only 6.5% of orthopedic surgeons are female. That number, I think it is definitely increasing. There are more female residents now, and so hopefully in the next 10 years, there will be more females who are active orthopedic surgeons. But I think that as that number increases, the disparities in the care will start to go down as we focus a little bit more on research and specifically looking at women as they are very different from men. The innovation in orthopedics has traditionally always been focused on males and especially on male athletes, but I do think that is changing. And as I said before, for me, the confidence, the organization, and the collaboration that I learned in athletics really taught me and gave me the confidence to go into such a male-dominated specialty that I feel very strongly that I wouldn't have been able to do that had I not had that background. Above is a photo that's of me with one of my co-residents. I'm the one with the kind of giraffe-looking leg. And then my co-resident is Dr. Kaczynski. So it's the 2 of us that went through everything together. And she is now a hand and upper extremity surgeon at the University of Buffalo. I am very grateful I had her to lean on during my training, because I think sometimes it's just better to have a female perspective, and it was so helpful for me to always have her around. And then just to continue a little bit more about myself, so the sports world is definitely changing, and I think female athletes, when we think of them now, we think of Caitlin Clark, we think of Coco Gauff. They're really building on what people that I grew up with, like Mia Hamm and Serena Williams, really started. Still, professional sports, they're very male-dominated in their publicity, as well as in their medical care. I was fortunate to be a part of the medical staff for the Pittsburgh Steelers during my sports medicine fellowship. It was really an amazing experience. It was a lot of fun and definitely educational. But for me, my preference has always been, and that's why I wanted to come back to where I grew up, is taking care of people on more of a community level, getting to know people that I live around, and I really enjoy that part of it, and specifically taking care of more high school and college level athletes. But these are some photos from my time in Pittsburgh. My mom caught that one on the TV screen all the way on the left. She was really excited because I am in that photo with that red arrow. That is me. So that was very exciting for her to send that to me and say that she actually saw me on TV. So now kind of just getting back to the topic at hand and talking more about taking care of the female athlete. So I'm going to start with going through the risk factors for injury. And what are some of the innate differences between males and females that lead to different injuries in the female population? There are several different biological and biomechanical differences that can contribute to an increased risk in a female athlete. So just starting anatomy, right? First, anatomy is just different. Women generally have wider hips. They have a increased knee valgus, so increased knock knee, where your knees kind of come in more together in the middle. And women have greater joint laxity. This can all alter lower extremity alignment, and it can increase stress on various joints. An increased Q angle, that's what this photo is here, is the angle between the hips and the knee. It has been linked to higher risk of ACL injuries due to an increased stress going across the knee from the lateral pull of the quadriceps muscle. Now, I wouldn't say that is the reason that women tear their ACL. I think it's a combination of a lot of different things, but that's certainly one of the things to consider when you're thinking about the differences between males and females. So hormones. So the hormones that have really been studied are estradiol, progesterone, and relaxin. They're kind of the predominant ones that have been studied, and mostly this is research looking at ACL specifically. So this is a general talk about all the different risk factors, but a lot of this is going to go back to the ACL because that's where most of the research is in. And so these hormones have actually been studied as part of the menstrual cycle and how they relate to an ACL injury. Estrogen levels, they fluctuate during the menstrual cycle, and some studies do suggest that an increased level of estrogen, especially during the pre-ovulatory phase for women, it increases the ligamentous laxity, which leads to higher rates of ACL tears during that phase of your menstrual cycle. Relaxin is another hormone that women have, and there's different levels that we all have that are sort of innate to us. Those levels do go up during pregnancy. They are produced by the ovaries and the placenta, and that helps everything relax, which is what you need during pregnancy to help with childbirth. But it also, those levels can be different from female to female just innately, even when they're not pregnant. And they have actually shown that women who have a higher level of relaxin can have a higher rate of an ACL tear. They looked at NCAA Division I athletes, and they actually took their blood, measured how much their relaxin levels were, and they found that women with over a threshold of a number for their relaxin, they had a 4 times more likely chance they had an ACL tear. Now, that was a small prospective, small little study, but I think it just sort of fits with all of the information that we know or are starting to learn. There also is a meta-analysis just pulling together a lot of these studies that was published recently that does show that the risk of an ACL tear based on the menstrual cycle, you're more likely to tear your ACL during the pre-ovulatory phase, which is essentially, if you can look at this, it's basically when you're looking to the left of the slide here, to the pre-ovulatory area. These are all the studies that have shown that these are the time frames during your cycle that you're more likely to tear your ACL. And I think it's not perfect science, but it definitely is something to think about. When we kind of think about that, the kind of, next step that I think about is what do you do about that information? Is there anything you can do? And I don't think we know the answer to that. One of the things that has been proposed is looking at hormonal contraceptive or oral contraceptive medications. They work by keeping your estrogen levels very flat, preventing ovulation. So you kind of prevent this phase of increased estrogen during your cycle, and it has been linked to a few not very well done studies, but some smaller studies that do show that athletes who are on oral contraceptives have a lower risk or a lower rate of an ACL tear. And they kind of extrapolate that to being from a estrogen level that is much more consistent throughout the cycle. And so other things, it's not just all hormones, there's other biomechanical things that come into play. So neuromuscular control, it's very important when talking about injury risks. So females exhibit different landing patterns when they jump, typically having less knee flexion and less hip flexion. That can place greater strain on the ACL when you're landing from a jump or decelerating or making a quick agile turn and changing directions. This puts the knee a little bit more into the valgus, which we were talking about. That's the position where your knee is a little bit more knock-kneed. And that's shown up in that image here where your knee is sort of in towards your midline a little bit more. That also, females are also known to have the greater tendency just in general to collapse into that valgus. And that's compared to male counterparts, which can increase the risk of an ACL tear. And then women tend to also have weaker hamstrings, which is a big deal. And that's weaker hamstrings relative to the quad muscle. So when you have a imbalance of your muscles, that can lead to injuries around your knee. So if you rely more on your quadriceps tendon or your quadricep muscle during activities, which women tend to do, it can increase the stress across the knee joint. And this is because the hamstrings are a dynamic stabilizer of your knee. They essentially are preventing the tibia, the lower leg bone, from sliding forward. And if you're not able to do that, you're stressing your ACL because your ACL is also trying to prevent your tibia from moving forward. So if your hamstrings are weak, your ACL is a little bit more tense, it's got more stress and strain going across it. And then you are more likely to tear your ACL when your hamstrings are very weak, or if the balance is wrong and your quads are very strong and your hamstrings are weak. I think also when we're talking about female athletes, nutrition is a vital thing to bring up. I don't think we talk about it enough. Adequate nutrition can help prevent injuries. Female athletes are more likely to have an inadequate caloric intake and deficiencies in key nutrients, including calcium and vitamin D. Those are essential for bone health and injury prevention. Women also, just in general, have a higher percentage of body fat. We have less lean muscle mass, and we require more oxygen consumption with doing weight bearing and cardio activities, and that's as compared to the male counterparts. That all means that it's even more important for us to focus on the nutrition and what we put into our bodies, and that we have enough fuel to do everything that we want to do. This is, the injury risk goes up because it's linked to a state of low energy availability, which basically just means you have less, you're taking in too few calories and you're putting out more calories than you're taking in. And if that is a state that you are in, it has been shown that that can lead to what's called relative energy deficiency in sports, or RED-S. And it's a state of basically maladaptation in athletes where they actually have impaired physiologic functions, low bone mineral density, and hormonal dysfunctions. And this increases the risk of female athletes having injuries. So I think talking about nutrition and food as a means to fuel the body and optimize performance is an important part of keeping female athletes healthy. Young women face a disproportionate amount of pressure, especially social pressure, to fit into a mold that doesn't necessarily align with something that's going to have peak performance that fits into that mold. And I think a healthy body image is part of being a female athlete, and thinking about nutrition as a way to stay active and healthy, and not as a way to control certain things that go into your body is very important and can definitely prevent injuries or things that can change your overall hormonal balance. So we brought up a lot of risk factors, but what are the actual injuries? What are things that are more common for a female athlete that we need to keep an eye out on? So I guess this is the elephant in the room. We talked about ACL a lot, and I think there are more studies published on the ACL in sports medicine data than any other subject, so it always comes up. ACL injuries are actually up to 6 to 8, depending on what you look at, more likely to happen in a female athlete as compared to a male athlete. And those are particularly in sports involving pivoting, as well as jumping, so soccer and basketball. We already discussed the risk factors for injury, including the anatomy, the hormones, and the neuromuscular control that can lead to this increased risk of an ACL tear. But in addition to the increased risk of injury, treatment success has also been shown to be very different between male and females. there is a much higher rate of a re-tear after an ACL reconstruction if you use a hamstrings autograft in a female. It's about almost 18% high, 18% risk of a re-rupture versus about 6% of a re-rupture if you use a different graft, like a patella tendon graft. That does not translate to males. It is very specific for females. So I think it's very important to know this, and if you're a female and you're under the age of 25, that you don't want to have a hamstrings graft if you're going to have an ACL reconstruction because of the rate of re-tear that's associated with. I think now it's a little bit more mainstream, and I do feel like just within my practice, especially, that hamstring grafts you see less and less, but it's definitely something to know. If you are going to see someone and if they are talking to you about a hamstrings graft, it's important to know, the differences between a male and a female. So other injuries, the ACL, I've been taught in fellowship that the ACL isn't everything, that there are other things besides the ACL. So stress fractures. Stress fractures are more common in females as compared to men. And that's due to factors like smaller bones. We actually have smaller bones, lower bone density, and nutritional deficiencies, especially in female athletes. And this also comes into play with overtraining and not allowing enough time for rest between your days of your training, and really just trying to be as great of an athlete as you can. It can actually be detrimental to your health. So this is a photo up here. This is actually a stress fracture of a femoral neck. So when we think about stress fractures, a lot of times we think about things that just need to take a break and let them heal, but there also are stress fractures like the femoral neck here, where we actually do surgery to fix this because of the potential devastating consequences if you leave it alone. So it's a really big deal when we think about stress fractures and overuse injuries. So we want to make sure that we're always being healthy, we're always eating enough, and we're training in such a way that we have time to let our bodies heal. Okay, lost the bounce. So I think there's also, I don't want to just leave stuff out, but there are other common injuries, less talked about kind of ailments that are more common in female athletes than in male athletes. So patellofemoral pain syndrome, some people call it runner's knee. It's a condition that causes pain around the kneecap, and it's more common in women, partly due to the anatomical differences and the muscle imbalances, but it's also partly due to that quad and hamstring ratio. So it's really vital for women to work on their quad. And also to get that ratio to be a little bit better and keep the hamstrings really loose as a part of that. Ankle sprains are common in everybody, but they are more common in women if you actually look at the numbers. And they are likely secondary to that innate ligamentous laxity that women have. This is also impacted by kind of sport-specific things, activities like windmill pitching, which is very specific for females who do softball. There aren't as many males doing that kind of motion of a windmill pitch. So shoulder injuries, are more common in women. They are in general more common in women, but also kind of sport-specific things you have to consider. And so what are the prevention strategies? I think it is obviously very important to talk about the risk factors and the injuries, but then to kind of bring it back and focus on what can we do to prevent certain injuries from happening. This is a photo of Olivia Reeves. She won the United States' first Olympic gold medal in weightlifting, male or female, in 24 years. This was in the 2024 Paris Olympic Games. So she's a weightlifter, and I think a lot of what I'm going to kind of go forward on is promoting a lot of weightlifting and strength training for women. So proper strength training. I think if you look at some of the studies that were done like the early 2000s, they polled coaches, female and male coaches for athletic teams. They were mostly male coaches, but they were also taking care of female sports. And they actually asked them, how much do you incorporate weight training in your programs? It was about 60% of the male sports had a weight training program, and only about 9%, I think the number was, so less than 10% that women were actually being involved in weight training, getting in the weight room. And weightlifting is vital to injury prevention and keeping strong. So incorporating exercises that target the hips, core, and hamstrings can help improve the balance and reduce the risk around knee and ankle injuries specifically. And then we talked about this already, and I feel like broken record now, like the quad dominant is a big part of this, putting the stress on the ACL. So focusing on the hamstrings and the quads as well.
So I have a question about that. Traditionally in my training a while ago, the quad hamstring ratio is like 3-2.
Yeah.
So is that wrong?
I just don't think we know.
Okay.
That would be my answer, I guess. I don't think we have a perfect, I think it's the way I like to think about it is that you don't want to ignore one thing, obviously, or the other thing, but I don't think we have an answer to the actual ratio.
I mean, you're
To
not
try to-
hoping to see it try to be 1-to-1.
No,
Okay.
no, not 1-to-1. Still, our quad should always be stronger.
Yeah.
But I guess it shouldn't be such a dominant quad for anybody, but it just tends to be that males have a closer ratio than females do. So trying to bring the female ratio closer to what kind of a male would have. And I just think most of it is that the hamstrings just get ignored. And then that's, part of why they get weaker. But I don't think we have an answer to the perfect. I don't think we can say anything that we know perfectly, but especially I don't think we know that. Neuromuscular training. So strength training is not an isolated thing where you're just trying to build muscle. You also need to learn how to control your strength, which is a big part of this. And so neuromuscular training programs actually focus on just that. So proper jumping and landing, especially landing techniques, balance and agility, that can improve your neuromuscular control. And that's been shown to decrease things like ACL tears, ankle sprains, and ankle fractures as well. So there's many validated prevention programs that focus on strength and neuromuscular control. They have all been shown to actually decrease the rates of an ACL tear, things that we don't really tend to do in day-to-day practice, but they are validated. So I'll go through a few of those. So this is specific to an ACL and prevention of an ACL. So these are 3 different examples of validated training programs. So the Sports Metric and the Prevent Injury and Enhance Performance, the PEP program, those have both been shown to reduce ACL injury tear or ACL risks when looking specifically at athlete exposure in a high school female athlete who's participating in basketball or soccer. There was also a separate analysis of these 2 programs, and they also showed that these significantly increase the hamstring strength as well as the isokinetic strength and improvements in both the hamstring and quad ratio that we've been talking about. So essentially these programs are focusing on the hamstrings and the quads to help prevent injury. The FIFA 11 program, I think as FIFA 11 plus now, so more than 11 exercises, but the FIFA 11 plus is a validated program that FIFA, the organization, actually studied in professional soccer players in Europe. And they found that through a series of warm-up exercises, if they were actually done before each game or practice, they had a significantly decreased risk of an ACL tear in those athletes. Some of their studies quoted as 80% decrease of a risk. I don't know if I believe 100% that it's 80% decreased, but I definitely think it is something worth just knowing and considering for the future. So this is the actual FIFA 11 program. It's published online. The program needs to be done on a routine basis to be effective, and compliance is really the problem with this. You have to do it before every activity that you do. And so this is just the 8-minute warm-up that it includes. And then from there, there's about 30 more exercises in the kind of middle of this, which is 10 minutes. And then as we go to the end, this is another 2 minutes. So the whole total is about 20 minutes of your time for just warming up. So people don't do it, which is the problem with it. But I think it's a very interesting thing to consider, especially if you're part of a coaching staff or an athletic training staff. Even just incorporating a few of these things into the warm-up can be very helpful. There are now apps that you can actually download that have this program, and you can track, somebody can be in control of the app, and you can have players have profiles where you can actually track how many times they're doing it, if they're actually being compliant with it. You can do it for yourself if you want to do it for yourself. But I think proper training is incorporating a really good warm-up, and this is sort of part of that. So we're going to circle back now to kind of nutrition, because we talked about it as a risk factor for injury, but what does nutrition really mean? And I think it is really, it's adequate nutrition to fuel your body to be able to do the strength training and the neuromuscular control that you really need. So consuming basically a balanced diet. You need sufficient calories, whatever those calories are. Calcium, vitamin D, those are things that are crucial for maintaining bone health and preventing stress fractures. And then focusing on rest and recovery. That's also really important to allow adequate time between training sessions, and that can prevent some injuries as well. And then I think also remembering a gradual training approach. So if you're going back into sports, you have been out for a little bit, or you're transitioning to a new sport, remembering that you can't just start at 100%, that you need to gradually increase your activity rates, gradually increase the intensity of those workouts, and remember you need more rest time in the beginning to allow your body to recover. And then iron supplementation, especially for women who are menstruating, it's really important to remember that iron is a big part of that and you're losing blood. And so making sure that you're up to date on labs, and if you're feeling fatigued, there can be medical reasons that you're tired, not just that you're up too late at night, that you're not sleeping well. There are medical things that can go along with that. And sleeping, I think, is also a big part of this. I didn't put too much of that in here, but I feel like sleep hygiene is a big part of all of our lifestyles and really important for especially athletes, but anybody, to have really good sleep hygiene to help with the kind of rest and recovery that we need to keep active. So I was gonna just kind of talk about my my treatment approach a little bit. We talked about the risk factors, we talked about the common injuries and way to mitigate those risks, but kind of what does that all mean to me as an orthopedic surgeon, and what do I kind of take away from this type of stuff? And basically, for me, it's all about looking at goals. And when I mean goals, I mean talking to the patients who I see. So thinking about their goals, looking at an individualized approach to their care, and then communication. I think that's the biggest thing. I think we could all agree that communication is a big part of care for an athlete. So if, I don't know, does anyone play sports who's here? So what sport do you, I don't know, so.
I'm a swimmer.
You're a swimmer.
Triathlon.
Triathlon. So for you, your season is all the time, right? So it never really ends. So for that, it's something that, if you have an injury, for me, I think about basically the fastest way to get you to slap tear, right? Yeah, everybody has a slap tear. And then, I think it's important, you brought up a slap tear, I think it's a great example of something that I think of for mostly overhead throwing athletes. Swimmers, I think more like serratus, kind of anterior, and kind of the stuff that comes along with that. But for an overhead shoulder slap tear, it's important to know that slap tears aren't harmful, that it's okay to have a slap tear, that it's about the pain that causes you that we want to treat. And so jumping to surgery is not always the right thing to do for a slap tear, because it's not going to get you back into the pool any faster than it would to kind of recover that with physical therapy. And I think jumping into surgery is usually the wrong choice for most injuries that especially high school athletes have, when a slap tear can actually be adaptive, where actually having that tear at the top of your labrum can allow you to have a little bit more motion when you're going through your swimming motion, which is actually beneficial. So if you fix it, you're taking away a benefit. So it's really been about focusing on the treatment for the pain, which most of the time is then related to more of, it's more, I guess, related to the biceps tendon a lot of times, as well as sort of the rotator cuff muscles around it. But then for me, it would be thinking about your goals, right? Are you gonna try to be a triathlete for a profession and make money as a triathlete? No. So then, do we need to push the boundaries to get you back to going full out, doing everything you can, or do we have the time to really rehab everything and make sure that you're better before you go back? Those are, I think, the important things to think about when you're taking care of an athlete. The season that they're in, their goals that they're gonna, what they want to do moving forward, what year they are in school. Are they in a recruiting year for a sport that they really want to play for college? Then do we take a little bit of risk and let you play through an injury, or do we take you and sit you on the sidelines? I think those are all important discussions to have, and that's kind of how I think about all these risk factors, all the different injuries that women get, and then kind of talking about them and figuring out the best strategy for each person. So that's sort of my general treatment approach. And then this is just sort of summarizing, we talked about biological and biomechanical differences and how they contribute to the increased injury risk in female athletes. We also talked about more specific injuries that are more common in females, and then sort of prevention, focusing on controlling those risk factors to the best of our ability. We can't control everything, but we can certainly control part of it. So thank you all for coming, and then if you have any questions, I'd be happy to answer any ones that I can, if I have the answers.
When you're doing ACL surgeries, what type of graft do you tend to go for?
I like the quad graft. I think that's a great question. I probably should just give this talk on ACLs, because I think that's mostly what to talk about. I say quad because I jumped to quad, but it's because I like the quad graft. But that's a perfect example of asking somebody what they do. So I think the gold standard still is a BTB. If you're looking at an NFL player, they're going to get a BTB. I think that's going to change in the next 10 years, but right now it's still a BTB graft for them, a patella graft. But if I have a wrestler, I'm not going to do a patella graft for them, because they're going to have kneeling pain for the rest of their life. And anytime you're wrestling, you're on your knees. And so to me, it doesn't make sense to do a BTB graft. I would much rather do a quad graft in that person. because I think they'll do better with that. I think it applies beyond athletes too. When you think about people who are painters or even religions who are praying a lot, you don't want to do something to them that is going to cause them pain every time they kneel. So then I kind of favor a quad. If it's a senior in college who's going to go play Division I football, I think probably still the gold standard would be a BTV, and that's mostly because actually as part of the recruiting process, if they know you have an ACL, they want to know what kind of graft you had.
Does that change for gender? With females tend to be more fond of it anyway. Does that change?
No, I don't. It's interestingly, we are actually studying, or I was part of a study when I was in my fellowship, and it hasn't been published yet, looking at that to see if quad grafts do better in women than in men, or basically just looking at a BTV versus a quad, and if there's a gender-specific graft. The only thing we know, I would say right now, is that hamstring is not the best graft for a young woman. I don't think we know between the quad and the BTV graft, but the quad graft, one of the issues with it is the size of the graft that you put in, and it's been shown now that if we always do a 1 centimeter BTV graft essentially, and now if you correlate that, everybody just started doing the same thing with a quad and putting in a 10 millimeter graft, it's been shown that can cause some impingement. And so now making smaller grafts, most of the time now for a quad, I'll put in an 8 millimeter graft, which is a lot smaller. And for women, that's important because the notch size where the ACL is smaller in a female as compared to a male. So I think I tend to be a quad person, and I think that's just the way I was trained more so than anything. But I also just want to talk about whoever I'm with is the risks and the benefits. So essentially the risk of knee pain after a BTB versus the risk of potentially having a weaker, there are some studies that show there's a subclinical difference in quad strength after a quad graft. So just what risk you kind of want to take on as a patient. But I just like the quad. Any more questions?
For risk for females like over 25 with a hamstring graft,
Yeah.
is that still very high for retail rate?
No, the study, we don't know, I guess is the short answer to that, but the study was looking at women up to 25. I think over the age of 30, I would consider any graft. I don't think it's wrong to do a hamstrings graft in someone that's older. I don't think we necessarily have the answer to it, but I also don't want to kind of be so negative about the hamstrings because that's been the graft we've used for the longest amount of time, and it does really well. It just does have that higher rate in young women of a re-tear, but I would say it's fine, over the age of 30. But I just don't think we actually have the data to say that yet.
What is the reason that the hamstring graft doesn't work as well in young women?
Yeah, a lot of it is to do so you harvest the hamstring itself. So hamstrings are already weaker in women, and so you're taking something from an area that's already weaker. And then the size that you get in women is actually smaller. So the hamstrings themselves, the tendons that you harvest tend to be a lot smaller. So a lot of times you basically take a long tendon, you have to wrap it around a bunch of times to get it to the threshold is 8 millimeters. And in women, you don't always get to that threshold for the actual size of it. So you add in an allograft, so a cadaver tissue to make it bigger. So I think that's a big part of why it fails in women is because one, hamstrings are already weak, so you're taking out something and you're causing them to become weaker, but then they also, the size is just not the same as a male. The hamstring tendon size is not the same. So it's kind of a combination of everything. And again, I feel like I don't want to be hating on the hamstrings graft so much. It does work very well for the right person. Yes, it definitely works. Questions? So this is my information. I am pretty much always available. So I really don't mind if people have questions and they want to reach out to me. It doesn't, I'll get back to you when I can, but that's my email and my cell phone number. So I try to be pretty responsive with questions and sort of communication. So if you do have any questions that you think of later or you want to ask them, I'm more than available, whatever comes up. So, yeah.
So what type of surgery are you performing currently?
Me?
Yeah.
So I do basically and I think of sports medicine and trauma, I do both, and I think they go kind of hand in hand because sports medicine is like the soft tissue trauma, and then trauma is more like the bone trauma, I guess I think about. So I do basically any fracture care, I will do fracture care, but then for sports, I tend to focus more on shoulder and knee. I don't do hip arthroscopy. So that would be one thing I don't do, but otherwise I do all shoulder and all knee as far as sports medicine, so arthroscopic surgery. And then I also do shoulder arthroplasty, which is kind of part of sports medicine, but a little bit kind of a caveat of a little bit different, I guess, patient population. But yeah, so I really enjoy both shoulder and knee surgeries. So for me, when I think of shoulder injuries, I think of labral tears, rotator cuff injuries. I also do elbow, so at UCL, I don't see that, it doesn't happen that much, like a true UCL injury, but I do feel, I trained with Jim Bradley, who's kind of the pioneer of UCL surgery in Pittsburgh, so I felt like very comfortable with the UCL if it ever comes up. And then for knee, ACL reconstruction, any of the ligamentous reconstructions, but also cartilage. I think there's a lot of new techniques for cartilage growth, if you want to call it growth, but ways to manage cartilage defects. I think there's a lot of new things that we can do that have research to support them. I don't know if it's going to last forever, but it's something I like to do as well, cartilage.
As a female on a male-dominated sports team, aka the Steelers, like football, right?
Oh, yeah.
How, I mean, in general, athletic trainers, PTs, like surgeons, are just not seeing them on the sidelines and
No,
most sports like that. How did you feel you were treated? Were you treated any differently? Were there certain circumstances that you had to negotiate or navigate around that you weren't expecting?
No, I was treated very well at the Steelers. Their organization, everybody, a part of it, was very kind and welcoming. And like I said, I worked with Dr. Bradley. He's the head team orthopedic surgeon there, and so he's been there for many, many years. So they all know him. They also know that he comes with a fellow, which was me. So like Mike Tomlin, he didn't know my name, I don't think, but he called me fellow. So he knew who I was, like what role I had there, and it was, it never was a thing. It didn't matter. And I think part of that was Dr. Bradley, who was one of my mentors. He just made it not a thing, meaning I was always in the room. I was there when people were being examined. It wasn't a question. It was just I was there. It only came up once when one of the players was swearing, just casually, and then he looked at me and said, "Oh, I'm so sorry, ma'am." And then Dr. Bradley, I think, handled it great, and he just looked at him and he said, "What? You don't think she's ever heard a swear word before?" And that was it. That was the only time I ever felt different, I guess, in any of it, and it wasn't even a big deal. It was honestly just more respectful than anything else. But I definitely remember that because it was pretty funny. But no, I think. There are now, if you look at it in the WNBA, I believe it's about 30% of the WNBA, that they have the highest rate of female medical professionals, and it's 30%. It's not even that high, like when you think about it, which is crazy. And then there are, I think it's 6% of NFL team, not necessarily just team physicians, surgeons, but the medical doctors as well. It's about 6% of them are women. So it's changing slowly, but not that much.
What made you want to do sports medicine? Like,
It's a tough question.
either that, like, sports medicine and go into surgery versus like physical therapy.
Oh yeah.
What made you want to go into like the field of sports medicine
Mhm.
and treating athletes?
I think, well, one, I decided to go to medical school after college, so I worked for a little bit and just had a job, and then I decided I wanted to go to medical school. Why? I honestly couldn't tell you. I think it was just a combination of who I worked with. I worked for an MD, PhD, who kind of, I realized I didn't want to do research only and be in a lab. I wanted more like day-to-day talking to people and kind of hearing about people, and I really just liked hearing people's stories, and I think that kind of got me to go into medicine in general. And then in medical school, for me, I always thought I wanted to do primary care or oncology, and then I did a rotation where I operated and I was in the OR, and then I realized I want to be in the OR, and then I did a rotation with orthopedics, and it was just the most fun. We have the most fun. I think of all the specialties in the operating room, orthopedics have a lot of fun, and it just felt like a team. Like it's a very physical, surgery in general is very physical, and I think there was a big component of it that you're all working as a team. Even as a medical student, I felt that way, and so that's what made me want to go into orthopedics, was just to become a part of that team. And then sports medicine just fit for me. I like arthroscopic surgery, and I really like it. I think it's challenging and fun. I think it's exciting, all the things you can kind of do with a scope. So just like the small cameras and small incisions, and you can really challenge yourself to do a lot of things kind of on the inside that I don't think we could do like 20 years ago, which I really liked. and I still like, in blanket statement, I think I would have been happy doing anything, most things that are involved with like athletics. So a physical therapist, PA, all these types of athletic trainer. I think I would have been very happy doing a lot of those different things. It just so happened that I ended up going to medical school and then making that decision to do surgery. And I love doing surgery. I love the tangible aspect of it, which is a big part for me, is just being able to fix something, like look at it and fix it. It's very, I guess, instant gratification. And then the physical therapist gets to do all the hard work and make sure it works out in the long run. So I think the team kind of aspect of it is what I like.
I had a couple questions. You talked about some warm-up
Yeah.
specific things for athletes. What about cooling down?
Yeah.
Like after game, because usually a lot of people are like, oh, I'm done, and
They
they
just
leave it, and
yeah.
especially like at the high school level, there's after games or meets or races, there's not a lot of that I've
Mhm.
seen. And the second question I had was, what age is appropriate for female athletes to start lifting weights and how?
Yeah, those are tough questions. So the first was for cooling down. Yeah, no, I think it's just neglected. No, these are just, I picked out the validated studies that have been done to show actual studies that have been shown to decrease risk based on pretty well done actual research studies on them. They don't have the same things for cooling down. It just isn't out there. Do I think it's important? Yes, I definitely think it is important not to just stop and be done. But there is not, at least to my knowledge, there's not a published cool down system like there are these warm up systems. The PEP program, if you go onto their website, they do have cool down videos. They have a lot of cool down programs, but they're not validated the same way that the warm up stuff is. But it's definitely important. And then your second question was on when to start weightlifting. I think learning the technique of weightlifting, there's no wrong time to start learning that. So just being comfortable in the gym, being comfortable with the idea that you're gonna go lift weights or go to a workout class. I don't think there's a time that I would say is too young to just be comfortable doing those sorts of things and learning the techniques and using lighter weights. That's still weightlifting. And I think that can start at any age, even if they're 1 pound, 2 pound weights, just to learn how to do it. But I really feel like learning to be comfortable in a gym with the idea that it's okay to go into a gym and lift, deadlift or to clean, jerk and clean, things that you traditionally see men doing, that those are okay things to do. I think any age is fine to do that. The weight and how much weight, I would say doesn't necessarily mean, even if you're really young, it doesn't mean you can't do it. It would just be that you have to use a really, really light weight. It shouldn't be strenuous on someone until they're kind of over into like high school where they're really trying to build muscle. And even then, it's not about heavy weightlifting. It's just about technique until you build up the strength.
Kind of building off of your question, is there a gender difference in like the epiphyseal plate in its development, and how how does weightlifting also impact that?
It's more timing. It's not necessarily that, at least it hasn't been shown that hormones in terms of estrogen truly affect that, but it's more timing. So women, it's the timing of the plate closing, but it's not, I think it's pretty much been debunked, at least to my knowledge, that weightlifting at a younger age is gonna stunt your growth. I think that was, I remember hearing that when I was younger, but it pretty much that's been debunked, that it's not necessarily that weightlifting at a younger age is gonna cause you to have stunted growth. Which is what I kind of think about still, but it's pretty much, that has been debunked in the literature. It's more, as far as the growth plates go though, no, it's more of a timing difference when women and men go through puberty. That's really what the difference is.
Is there specific exercises that women can do to help kind of prevent that knock-knee? Is it more hamstring work?
Hamstring, yes, but it's more the neuromuscular control when I think about that, is just being mindful, and it's a lot actually of the glutes and up at the hips to kind of control your pelvis more so. The Q angle thing, where the hips going, that it's because of the wider hips, that's what we like to talk about. I don't think it really has been shown to be more proportionate for women as well, so it's not necessarily the only reason that we do that. So it's a lot of the neuromuscular control. So it's more thinking about the glutes, and I tell most of my patients to do those like 1980s videos on the side of with Jane Fonda, because it really works in kind of getting the glutes really strong to hold your pelvis stable. and then we do what's called like a drop down test where you actually jump down and landing, and the way you land when you drop down is probably more important than the strength, the kind of control that you have.
What do you think about like bracing and orthotics to prevent some injuries or for recovery?
Yeah, so I don't want to say I'm anti-brace, but I think for me, I think of things kind of in buckets, right? So one thing is it a surgical problem or is it not a surgical problem? If it's a surgical problem and it needs to be fixed surgically, then, I like to say nothing needs to be fixed, but if it should be fixed surgically, then, surgery is the way you need to go. And a brace is not going to necessarily overcome your need for a certain surgery depending on what it is. And then as far as braces go, I think skiing is really the only thing that's really been shown is if you do have a knee injury like an ACL and then you go back to skiing after, a return to sport type of brace has really only been shown to be beneficial in skiers, not soccer, not any of the other agility sports. But I do also feel like some of the braces now, I like to think of them more as more proprioception and just more points of contact, kind of like KT taping. It's almost like just more points of contact in somebody's leg that their brain can then feel where their knee is in space. And I kind of feel like that with a lot of the braces that people wear. It's sort of similar. But no, there's no way to wear a brace to prevent certain injuries. And then orthotics, if you have a true, deformity of your foot, that would be very different. Like if you have a true rigid flat foot, that is something that's different than when I think a lot of people wear orthotics more for comfort and to help with the lateral aspect of their foot so it doesn't move so much. That would be more helpful in preventing like ankle sprains because that keeps your foot a little bit more rigid, but it's not something that I would say I recommend routinely as a way to prevent injury. It's more I want your body to control your leg, I want the muscles to control. I want you to be mindful and control yourself.
Do the zero drop or really low drop sneakers that are fairly popular right now make a difference with ankle sprains?
I don't know. I'm gonna just say no. I don't think so. But I think there's a lot of claims out there. I just try to focus on what has actually been proven and shown with data. Anybody can tell you that something works, and if it does work for them, great. It's good for them. It's a good thing. It's not a bad thing. When I try to counsel people on specific stuff like that, has it been validated in a study? Yes or no? And if it hasn't been, then it's the costs that are associated with these things. And maybe they do work, but they might be very expensive, maybe they don't work. And I can't tell you one way if they do or not. I don't think it's harmful in trying if you're willing to put out the money for it, but I don't think it's something I can stand up here and say it's gonna help with X, Y, or Z. Any other questions?
Thank you.